Hello, everyone. I'm so sorry I couldn't be there with you all in person this evening, but I'm out of town at the AABB Board of Directors meeting in Bethesda. I'm really proud to be awarded the Lee Award from the Illinois Association of Blood Banks. And I did just want to share a few minutes reflection with you all about my career up to this point. So I'm going to talk about life of a pathologist. Laboratory medicine is a team sport. So many of you know that I am an avid football fan. My favorite team is the Baltimore Ravens, and their coach, John Harbaugh, once said, "My coaching philosophy can be summed up easily. The three most important things are the team, and the team. Everything we do is to make the team better. Individuals can let their light shine, and we encourage that, but nothing should detract from making the team better." So, tonight I'm going to talk a bit about coaching and mentoring. Uh, every team has a coach, often there's more than one. A good example of that is in football, where you have more than one coach. And this article from the New Yorker is by Atul Gawande, who's a surgeon. And he talks about how he actually hired a coach to observe himself in the operating room so that he can improve his surgical skills. So even someone who's already reached the end of training still can achieve value from continued coaching as well as mentoring. The difference between a coach and a mentor is an experienced and trusted advisor, while a coach is a person who observes, judges, and guides. Dr. Gawande also has a TED Talk, the link is here, and he talks about this in the TED Talk. So these are my parents, Robert and Lona Campbell. My parents were married in 1954 in Albany, New York, which is my hometown. And there were four children. I have three brothers. I'm the only girl. And my two oldest brothers, Robert and Kenneth, who Robert is on the left of this photo and Kenneth is on the far right hand. Our brother in the middle is my brother Charles, who's the youngest. So I was born between Kenny and Charles. Robert and Ken were born with severe developmental disabilities. And at the time, they're both 7 and 8 years older than me. We really had no idea about what was going to be in store for them. So my parents sought answers. So the man on the left was our family pediatrician, Dr. Anthony Mastriani. And in Albany, New York, which is the top right-hand photo, which is, as I said, my hometown, my parents took us to see him, and he actually, through his connections from his training, connected us with people at NIH. And so my father drove us from Albany to Bethesda, Maryland, and we saw several experts. I remember this, even though I was very small. I remember this trip. I was probably about in kindergarten. And I was actually really impressed because one of the scientists that my family saw was a woman. And up until that point, obviously, as a small child, I didn't really fully understand everything that was going on. But I remember being impressed by this woman and thinking, I'd like to maybe do that someday. What she's doing, help people find out things and help them find answers to questions. So subsequently, by that age, I already knew, I was pretty small, I already knew I wanted to be a physician. And so I ended up at medical school in my hometown at Albany Medical College. Once I got all the way through to fourth year, I had thought I wanted to be a internist, to go into internal medicine and to perhaps eventually become a cardiologist. That plan kind of got dashed by the chair of pathology at Albany Med. At the time, that was Dr. Jeffrey Ross. Dr. Ross, before every lecture, would show slides from College of American Pathologists about what a great career pathology was. And I thought I probably wasn't paying that much attention, but apparently it sunk in. I did do an elective rotation fourth year. I remember sitting across the microscope from Dr. R. Foster Scott, who was on the right-hand side. And I just thought, this is super, interesting. It's very impactful for patient care. And, I kind of put it in the back of my head that it was by the time I did this rotation, it was too late to change the specialty I had selected for the match. So I said, I'm going to do internal medicine. And if I don't like it after the first year, I'm going to switch. And so, CAP should know that their advertisements are actually quite effective, because I did end up switching out of internal medicine into pathology. So here I am with my co-residents at University of Maryland. To my left is Dr. Andrew Blokowski, who was our chief resident my first year. And so when it was time for him to schedule the residents, he said, well, I'm going to put you on blood bank rotation relatively early in this year, because I know you won't be afraid of the ICU. I had no idea what he was talking about. However, once I got on the rotation, I discovered this was everything I liked about medicine. The hematology, I was introduced to clinical pathology and laboratory medicine, and I just decided I was going to go into blood banking and transfusion medicine. So I ended up doing my fellowship at Johns Hopkins. This is, many of you know, this is Dr. Paul Ness, who was one of my first mentors in the field. Dr. Ness really guided my career development, and actually gave me a task the first few months of my fellowship, which was to develop an animal model of delayed hemolytic transfusion reactions. And he gave me this charge, but actually kind of let me do a lot of this myself. And so it was really, I spent a lot of time in the Welch Library at Johns Hopkins, going up and down the stacks, looking for examples of blood groups of small mammals, horses, cows, pigs, sheep. Dr. Karen King had already developed a model of using rabbits. But the trouble with rabbits is that no one makes transgenic rabbits, and you wouldn't be able to really evaluate all of the the questions that we had at the time related to delayed hemolytic reactions. And this interest in this area of transfusion medicine was really spurred by this case that I published of an acute hemolytic reaction of a patient who made an anti-IH patient with sickle cell disease. And so the article on the right is the resultant paper from the animal model that I did end up developing using the transgenic DuffyB expressing mouse. That model was really developed with a great deal of help from Sue Shirey, who was the lead technologist and directed the reference lab at Johns Hopkins Blood Bank. Sue is on the left-hand photo. And my other tremendous mentor, Dr. Karen King. Karen is in this picture. On her right is Karina Yazdan-Bacchus, who's the director of research at Lindsley Kimball Research Institute at New York Blood Center. And on Karen's left is Dr. France Perrin from the French Blood Service in Paris at Henry Mondor. So These women were all instrumental in helping develop additional research, particularly related to that I have ongoing research related to hyperhemolysis. But Dr. King and Sue Shirey really spurred my interest in immunohematology. And so subsequently, I continue to stay in contact with a lot of my colleagues at from Johns Hopkins, as well as other institutions. These are people who've done their fellowship at Johns Hopkins. In the back, many of you know that's Daryl Triolzi, who's the director of transfusion medicine at University of Pittsburgh, and Aaron Tobian, who's the current director of transfusion medicine at Johns Hopkins. But I have to say, without Dr. Ness and Dr. King, without their mentorship and valuable coaching as well, I would have had probably a different career trajectory in this field. After I left Johns Hopkins, I came to University of Illinois, and at first it was just myself and Dr. Vodanovich, who's in the center photo on the center photo on the second row, and Dr. Allison, who's on the left, and Dr. Lauritsen, who subsequently joined our team, as well as Dr. Vojan and Dr. Crane at the bottom of the photo. And along with the members of the laboratory staff at the Vitalant UI Health transfusion service, really have established a great team. So, we've continued to expand over the years, and I'm really proud of the fact that all of the physician staff in transfusion medicine at UI Health were trained at UI Health. All of them are graduates of our fellowship program. So laboratory medicine really is a team sport, especially if you're going to operate a large monthly red blood cell program as we do. And so this was published in Transfusion a couple of years ago. And we talk about what it takes to coordinate things for over 50 patients who get monthly red blood cell exchanges. The Sickle Cell Center at UIC has over 700 patients living with sickle cell disease. There's a dedicated outpatient clinic and inpatient service, as well as an adult sickle cell acute care clinic. Pediatric patients are managed in Peds Hemonc. They also have a STAR program for adolescent transition. And as I said before, we've got over 50 patients on chronic red cell exchange. One of the key things to make this program work is that communication early and often really has to be at the forefront of your mind. We manage new referrals through our EHR with a follow-up page to the fellow or resident. We advise on vascular access as well as scheduling. And the key thing here is obtaining red blood cells for our patients. Many of you know that this patient population has a high rate of red blood cell alloimmunization, and we really keep the Vitalant reference laboratory on their toes. I calculated at one point we used 24,000 milliliters of big C, big E, and Cal-negative red blood cells every month. So this requires a great deal of coordination with the reference lab, as well as the transfusion service and the hemopheresis clinic. So data that we've obtained from this practice, we published a paper in 2018 in Transfusion, looking at our antigen matching and outcomes as far as red blood cell alloimmunization. And we showed that if we just match for ABO and RHD, 38% of our patients were becoming alloimmunized. When we transitioned to extended matching for patients, once they made antibodies, there was still a 24% further alloimmunization rate. So because of this, we are doing true prophylactic antigen matching, where we're matching for CE Cal up front. for all patients. And we're in the process of analyzing this data now to see what our alloimmunization rate is. I'm expecting it to be much lower. If you look at the publications from Wyszynski in 2001, a true CE-Cal matched program leads to an alloimmunization rate of about 8%, and LaSalle Williams had a rate of about 7%, even with their extended antigen matching. And we know that the most common red cell antibodies in transfused patients with sickle cell disease are those of the Rh blood group. So, as I noted, because of this, our data shows that we really have to do true prophylactic antigen matching to reduce the alloimmunization rate. We use 100% leukoreduced as well, although that doesn't seem to really influence alloimmunization in and of itself. And of course, it has to be hemoglobin S negative. So I also wanted to thank the team that I am the most proud to be part of, which is the Lee family team. My husband, Charles, and our children, Christopher and Shelby, are the ones that have really allowed me to undertake this work and not mind me showing up at home at 9 o'clock at night sometimes. But, I am just really grateful for the sacrifices that they've all made over the years. So, in conclusion, both mentors and coaches are necessary for career development. Laboratory medicine requires lab directors, managers, administrative staff, and skilled technical staff working in concert with clinicians. Large red cell exchange programs require a team effort due to the complexity of patient red cell alloimmunization and vascular access, which impacts scheduling. So I'd really like to, again, thank the board of directors of the Illinois Association of Blood Banks, and I look forward to seeing you all again soon in person. Thank you.